My name is Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Johns Hopkins Bloomberg School of Public Health, it's my pleasure to welcome the Maryland Department of Health and Mental Hygiene to our school, with an especially warm welcome to Deputy Secretary Fran Phillips for joining us today for a second update on what healthcare providers need to know about the H1N1 disease and vaccine in Maryland. For those of you who missed the first update on October 22nd, you can find an archived version of that presentation on our website at www.jhsph.edu/MAPHTC. It's also on the DHMH website at www.dhmh.state.md/US/swine flu. We continue to be grateful to the leadership of the Department of Health and Mental Hygiene for their leadership in addressing swine flu in Maryland. In working to prevent the spread of H1N1, the department has forged new partnerships with employers, educators, and health professionals to ensure we're all involved in a proactive approach to keep Maryland healthy. Before I turn this over to our moderator, Dr. Peter Spinski, I'd like to ask those watching online to take a moment to fill out our sign-in sheet and evaluation so we have a better idea of our online audience and so we get your valuable feedback to ensure our webinars are educational and meet your needs. We also invite you to take this opportunity to explore our website and the trainings we offer and to take advantage of our public health training resources. Finally, I want to remind you that we will be taking questions for the presenters during this webcast via emails to maphtc@jhsph.edu. With that, I'd like to introduce Dr. Peter Zabinski, the Chief of Staff with the Department of Health and Mental Hygiene, who'll be moderating the program today. Thank you.
Thanks, Molly. Members of DHMH's senior leadership team is here today to provide an update on the status of key elements of the campaign in Maryland and to address questions from registered vaccinators who are watching the live webcast. We encourage all participants to email questions to maphtc@jhsph.edu. Now I'd like to introduce our panelists. Today's presentation starts with DHMH's Deputy Secretary for Public Health Services, Fran Phillips. Fran will give us an introduction to today's event and a strategic overview of the campaign approximately 1 month since Maryland's providers received the first doses of H1N1 vaccine. Dr. David Blythe, state epidemiologist, will cover continuing surveillance of the disease. Mr. Greg Reed, manager of DHMH's immunization program, will cover critical elements of the H1N1 vaccine campaign, specifically vaccine availability, distribution, and reporting requirements. And Dr. Aaron Millstone, a pediatric infectious disease specialist at the Johns Hopkins Children's Center and an assistant professor at Johns Hopkins School of Medicine, will address vaccination guidance for at-risk children. I'm now going to begin today's proceedings by inviting Deputy Secretary Phillips to the podium.
Well, thank you all, and hello, and again, thank you so much for your efforts for joining us today for another discussion on H1N1 in Maryland, the disease, and also, most importantly, the vaccination campaign. This is a discussion that's intended to be interactive. It is one that will have the opportunity to engage, we hope, Maryland's entire registered provider community, a very diverse community across the state, to engage with us in a discussion of this vaccination campaign, which really is of historic proportions. Moving through what I think will be very quickly a summary of today's webcast objectives, I would like to begin by thanking our hosts here again for this second webcast. This is a tremendous opportunity to communicate, and I do want to thank Johns Hopkins Bloomberg School of Public Health for their generosity in hosting this vehicle for us to communicate with providers across the state. Also, on behalf of our governor, Governor O'Malley, of Secretary John Colmers, and the entire public health staff at the State Health Department, we want to thank all of you who have worked across the state with us, sometimes in some frustrating situations as we prepare to immunize every Marylander that would like immunization against this novel virus. This is a virus which, as you know, has proven widespread. It has proven difficult for many, and for some it has proven deadly. So this is very serious business that we are engaged in, and to quickly recap the objectives of today's discussion as we go forward. First, to inform all of you registered providers of the current epidemiology, where the disease is and what the picture looks like in Maryland today. Secondly, to again have a discussion about the vaccine availability, the distribution, the ordering mechanism, ordering and reporting requirements. And then lastly, to have an opportunity to look at a very high-risk population among many in Maryland, and that are special needs children, and what kind of consideration we might make for them on their behalf. As you know, the context for this campaign seems to change weekly. If we can look back over the last 6 or 7 months, I think we can see that there's been a significant amount of progress, no doubt, progress, since this novel virus reached our shores the 3rd week in April up until the current date. Tremendous amount of planning has taken place, and now we are moving to a different phase, and that's moving really from planning to the implementation phase of the campaign. We did, throughout the summer, anticipate a resurgence of disease as we were doing this planning, and in fact, clearly that resurgence of disease has come about. Over the previous months, then, on a national basis, the vaccine research was undertaken, vaccine development and production was undertaken, the vaccine was licensed, and now we are beginning to enter that phase of vaccine distribution and finally administration to people. Again, in the context of widespread disease, and many of you are providers who are working with patients and families who are encountering that disease. As Dr. Blythe will mention, we now have over 500 confirmed H1N1 hospitalizations and, regrettably, 13 confirmed deaths at this point, and certainly we anticipate more hospitalizations and regrettably more deaths. Having spoken very briefly about the planning, you will hear about the results of that planning, that is the information system, both with regard to how providers become registered to vaccinate, as well as the distribution and the dose tracking information systems. Probably the most important part of planning was the recruitment of all of you providers to work with us. This is a Herculean job. It is one that we absolutely must have the engagement of the private health provider sector, and we certainly have that tremendous cooperation. Can't thank you enough for that. The range of providers that are now vaccinated, and there are over 2,000 of you currently, I'm sorry, you may be vaccinated but currently registered, a wide array of provider types. In addition to the 2,000 currently registered providers, another 1,000 are in the process of becoming registered. So who is in the audience? Who are the providers that currently are registered? The categories include local health departments, hospitals, pediatricians, internists, family practitioners and OBs, federally qualified health centers, schools and colleges, pharmacies, dialysis and urgent care centers, occupational health, long-term care, detention centers, community vaccinators, and the like. So I think you begin to see the array of interest across all these sectors with regard to participating in the campaign. The current challenge certainly is that we all know that there's simply not enough vaccine to satisfy the orders of all of the range of registered providers, and that truly has been frustrating, we know, for all of you providers as well as for us. The vaccine supply has been limited, as we understand, by the federal government as a result not of vaccine safety issues and not of distribution problems, but rather with unanticipated delays in the production process itself. So these are frustrating times when we have insufficient quantities. We have an alert public, certainly, a public that is interested in being vaccinated, particularly in those target groups, and we certainly have the array of providers ready to do so. So we talked about the target groups on the last webcast, and I'm sure that all of you are aware of the groups that are most at risk for serious medical consequences, and therefore the groups that would be the first to be vaccinated and are currently the first to be vaccinated in this phase of the campaign. Those are listed here. Again, the estimates in Maryland as far as the population for each of these target groups is listed there. What you can see is the bottom line. And the bottom line, over 2.9 million Marylanders falls into the category of the target population. I need to contrast that number, 2.9 million Marylanders, with Maryland's current vaccine allocation as of today, as of November 5th. Our allocation is 633,100 doses of vaccine. 633,100 doses over 2.9 million Marylanders. So what you can see is that we have received, or we have ordered, in fact, and not all of this has been received in the state, we have ordered less than 20% of the doses necessary just to meet the target population. So to put that in some graphics for you, we have, as well as other states, received periodic updates from the federal government as to how the vaccine production is going. And regrettably, every one of these projections, as they have come forward, and to date there have been 4 such national projections, every one has been slightly slower and slightly lower than the preceding one. So you can see the four projections here. The top line being the first and the most optimistic one, followed by a projection about 2 weeks later, the beginning of October, that showed a slight decline. Then again, a subsequent decline, and to the projection that we're currently working off, this one, which is the lowest. The original projection would have had roughly 1 million doses in Maryland by the end of last month, by the end of October. Under the current projection, which is this one, and the end of October being here, we are not close to, as you can see, we are not close to the 1 million mark. We get to the 1 million mark about the second or third week in November. So we are operating at about a 3-week delay, at least, from the original projections. As I said, we currently have, as of today, 633,100 doses that we have ordered on behalf of all of the providers, and certainly on behalf of the providers that are serving the target population, again, about 2.9 million Marylanders. So if we can move forward to how are we going to manage what we have in the short term as we continue to be assured by the federal government that the production process is underway and that there will be sufficient vaccine over time for all Marylanders that would require a dose, then what is the objective right now as we enter into about the 5th week of this slow start to the campaign? First and foremost, recognizing that there are many sectors of registered vaccinators who will not have the opportunity to get vaccine at this point. And certainly we look to our partners, the pharmacists, the community vaccinator community, the long-term care providers. These are essential vaccinators as we move into that phase when vaccine is abundant and we are no longer restricting vaccine to the target populations. So if you think of how we can restrict most efficiently the vaccine to the target population, the way to do so is to restrict the vaccine, as meager a trickle as we are receiving now, to those providers who directly serve or directly have contact with individuals in the target populations. So for those of you that we have been able to send some vaccine to, and that includes all health departments, pediatricians, obstetricians, hospitals, federally qualified health centers, what is our message with regard to the vaccine that you have? It is not sufficient. It does not meet your full order. We know that. And so clearly a message is, as soon as you receive that vaccine, please do everything that you can to very promptly administer it to target populations that are in your practice. We ask specifically that you actively promote this vaccine to at-risk individuals in your practice, that you then carefully prioritize, knowing that you are likely to have many more target population individuals in your practice or in your institution or amongst your workforce than the vaccine currently will support. So this is a frustrating and it's a very challenging effort. It is one that is made perhaps even a little more difficult by the fact that it's not simply a matter of the number of doses, but it's also the formulation. So certain individuals who are certainly in the at-risk population are not able to take some of the formulations, specifically the nasal spray, so that again complicates the sub-prioritization that really does need to go on in the provider's setting. And I think later in the presentation, Dr. Millstone will talk a little bit about how to tackle some of those difficult challenges. So lastly, we talk, and I think communication is so important. We are paying attention. We do want to hear what your concerns are. We want to hear what your suggestions are. We certainly have heard that, and we want to continue to hear and to make it better. And so some of the ways that we have been working on communication is emails, and we have now a very robust listserv of all registered vaccinators, and we have an increasing tendency to send emails out as developments necessitate through emails. Also, our website, which is listed here, the www.flu.maryland.gov, is one that we spend a lot of attention to keep that timely, particularly with respect to where vaccine is for the public, as well as behind the provider tab for specific information for providers. Webcasts such as this one has been a great adjunct to our communication, as well as weekly conference calls that we hold with providers, with partners across the state. We do have an email address there, h1n1info@dhmh.state.md.us. We encourage you to send us emails. Some days we spike and get about 200 emails or so a day. We work through those, and we see those as very important ways of communicating. And then lastly, for the general public, we continue to maintain a flu line during business hours. It will roll over, and there will be an announcement shortly when that flu line, same number, but rolls over to a 24/7 operation. As we lean forward to the day that it will come when we are able to widely promote this vaccine to the general public. We're not there yet because of the vaccine availability issues, and at this point we need to focus again on the target populations. So I will stop here. I look forward to your questions and further discussion, and I'll ask Dr. Blythe to come up and to talk a little bit about surveillance in Maryland. Thank you.
Thank you, Fran. And so I'm going to talk briefly about surveillance, hopefully give plenty of time for the main issues that we want to address today related to vaccination. And I mentioned this during the last webinar, so I'm not going to go over in great detail the system we have, or systems really we have in place to try to monitor influenza activity in Maryland. But I will just say that we have three main categories of systems. Those that monitor the overall influenza activity in Maryland, those that monitor severity, including hospitalizations and deaths, and those that try to characterize in a systematic way the viruses that are circulating in Maryland, particularly for the subtypes and sequences that those viruses are displaying, and then also to look for the emergence of antiviral resistance. So here are the various subcomponents of those three main systems. And just to show you some data here, this is where we are this week in Maryland. This is try to get the pointer here. This is time over in the x-axis and beginning in January of 2009. Here we are, the beginning of November right here. And you'll see we've had this big second peak of activity. We had a first peak here. This is the first peak of H1N1 activity back at the end of the spring and early summer. That declined, although persisted through the summer. Then we have this big second peak beginning around really the first or second week of September. And you'll see that there's been this huge rise in all these indicators of overall activity. But if you look, there's just the suggestion of maybe some peaking here, and we'll hope that's a trend. Certainly don't want to count on that yet, but we'll hope that that's the case. So a little bit of a decline in activity recently, just over the last week to 10 days or so, in the indicators of overall activity. In terms of other indicators, these are emergency department visits in this black line. You'll see that they too have gone up a lot over the last roughly 6 to 8 weeks, but just over the last week started to decline as well. So again, we'll hope that's a real trend that will persist, but we certainly can't say that yet. Hospitalizations are these bars here, and you'll notice those two have gone up dramatically throughout the month of September and October. Again, started to drop a little bit as well. That's the hospitalizations. And just to note that among these hospitalizations are people who are in those priority groups. So approximately 4% of the people who are hospitalized are pregnant women. About 10% of these people end up being requiring ICU admission, and roughly 4 or so % end up requiring mechanical ventilation. So although overall this disease has been relatively mild for many people, it certainly does, as was mentioned earlier, cause severe and sometimes fatal complications. This is to look a little more closely at the ages of those people who are hospitalized with lab-confirmed H1N1 in Maryland. And so that's what this pie chart is these various age groups beginning with 0 to 4 and then going around to the age 65 and plus. And you'll note that this section here represents children age 0 to 18. And if you look overall, that represents 43% of hospitalizations. But note that this is not evenly distributed among the ages, so actually 20% or almost half of these hospitalizations are in the very young children, 0 to 4 years of age, and many of those are in children who are less than 2. And then note that as well, although we don't see as much activity in the 65 plus population, we do still see some disease, including some hospitalizations and unfortunately deaths. So this is the age distribution for the hospitalizations at least. I won't go over this slide in detail, but this is the laboratory results and looking at the various subtypes that are being recognized by our state public health laboratory. And this is time in this x-axis, y-axis is the number of isolates that they have done testing for. And you'll see, first of all, that there's been a big increase and also in this system, a little bit of a decrease in the recent week in terms of overall number of specimens tested. This red color here at the bottom represents those specimens that are confirmed to be H1N1. And then these other color, the purple color is those where for whatever reason, the testing doesn't confirm any particular subtype. And then hard to appreciate on this slide, but there are other colors for the seasonal flu viruses that circulate and were circulating last flu season. And I'll just mention, because it's probably hard to appreciate on the slide, but basically everything that we're seeing right now is the 2009 H1N1. We're really seeing almost no seasonal flu strains circulating in Maryland right now or anywhere in the United States right now. So just to sum up, we have widespread distribution of cases, widespread throughout Maryland, widespread throughout various age categories and other risk groups. And we're seeing a slight decrease recently. We'll hope that persists, but we don't know yet. Almost all of what's being seen is 2009 H1N1. Fortunately, we've had no viral oseltamivir or Tamiflu resistance identified here in Maryland, and only sporadic cases throughout the world at this point, so that's good news. In general, the illness is mild to moderate, but we have had more than 500 hospitalizations and unfortunately 13 deaths. And as Fran said, we do expect those numbers to increase, unfortunately. And then finally, I'll just note that as shown that this epidemic so far does appear to be disproportionately impacting younger people compared to some seasonal flu epidemics. So I'm going to stop there and then turn this over to Greg Reed, who will give much more information about the actual vaccination program.
As Deputy Secretary Phillips mentioned, we've moved from the planning phase of our campaign to the implementation phase of the campaign, which primarily deals a lot with the vaccine distribution, the vaccine ordering. So I wanted to begin my conversation with telling you a little bit about where we are in terms of the ordering process and some of the steps that have to be done to get this done. The first phase is the ordering deals with the pre-registration. This is the process where a provider will make an initial indication to us that they're interested in receiving H1N1 vaccine. And we've tried to make this as streamlined a process as possible, where a provider will go onto the DHMH website and complete a pre-registration online survey. Once we receive that online survey, we then go through a verification process to verify a number of things, including the provider's professional medical license, as well as begin to assign them a unique identifying number, which is called a PIN. And that PIN number is extremely important for providers who are registering and providers who've already received their PIN. This is the way that we track your vaccine order, we track your vaccine shipping through the vaccine distributor, McKesson, as well as be able to communicate back with you regarding any other questions that you have. So once you receive your PIN, which could come to you through an email or through a fax, please be sure to store that PIN in a secure location somewhere where you'll be able to keep track of it for future use. Once the provider has received their PIN, they're given instructions on how to go to another location on the DHMH website where they complete the vaccine provider agreement. This is a federal agreement which was developed by CDC, and it outlines all of the conditions that are required to be able to receive the vaccine. It, again, is a document that was created by CDC and is extremely important. We know that a number of providers are very interested in having conversations with their legal or other members in their office before they complete the provider agreement. So we've made a sample, placed a sample provider agreement on the DHMH website for easy downloading and review prior to completion. Once the provider agreement is completed, the provider then has the opportunity to submit their initial vaccine order. Again, this is all done online through the DHMH website. And again, we want to try to make sure that this process has been as shortened and as streamlined as possible. We've cut down the time frame from the initial pre-registration to the placement of allowing the provider to complete the agreement and place an order down to 1 week. And again, we want to try to make sure that everything is done electronically, which is why we ask for an email to be submitted along with the pre-registration, as well as when you place your initial vaccine order. So your PIN number as well as a correct email address is extremely important to this ordering process. Again, once we've received the vaccine order and have reviewed that, we then make an assessment about how much vaccine we have available, and we begin to place those orders. We begin to prioritize providers to receive vaccine based upon who they're going to be serving in the priority group, as well as on their geographic location, as well as on the size of their order. Currently, at the moment, we're continuing to work with the CDC distributor, and they're only allowed to submit orders for more than 100 doses or more. So anything less than 100 doses, we contact that provider and ask them if they would be willing to accept 100 doses or more so that we can do everything we can to get doses to providers as soon as possible. Let me talk for a minute about where we are with the timeline. As Deputy Secretary Phillips mentioned, we began this process on the end of September when we were notified by CDC that there was some vaccine available for us to order. Since that time, we've begun receiving daily notifications from CDC in terms of how much vaccine we have available. Every day, my office receives an email, and we're given a number at that point in time of exactly how many doses we have available and in the different types of formulations. So every day when we receive that allocation and that number of the vaccine doses available, we begin to place those orders for the vaccine as well as the clinical supplies. Again, the vaccine and the clinical supplies, which will include syringes, needles, alcohol swabs, and sharps containers, are all made available free of charge since they're paid for by the federal government to all registered providers who receive an order. And then lastly, there is the process of the tracking of the vaccine that has gone to you in terms of the doses that are administered and the subsequent forms and other processes where you can let us know your process with the doses administered. This is a graphical representation of that entire ordering process I talked about. So you can see here that we have the vaccine that is made currently by 4 vaccine manufacturers. They, in turn, ship their vaccine directly to our centralized distributor, which is called McKesson. McKesson is the sole distributor for H1N1 vaccine for the entire country. They have 4 distribution plants throughout the United States. Maryland's distribution plant is in Ohio. CDC also receives from the manufacturers, when they ship the vaccine directly to McKesson, an allocation of the number of doses that have been shipped to McKesson. CDC then in turn gives this information to DHMH. We now know how many doses have been requested. by our registered providers. We then are able to send that information from the orders that we receive to the McKesson, which in turn ships that vaccine on to the providers. And you can see here the steps that the provider has completed in terms of receiving the vaccine from McKesson with the ancillary supplies, being responsible for the tracking forms and the administration, again, making sure that you vaccinate the target populations and returning that information back to us on a timely basis. CDC and McKesson have shortened the process from the time that they receive an order to us, from the time that they actually ship that order out. We now can expect orders to be received by our provider once they're placed by us anywhere from 2 to 3 days, which is a significant decrease from the original 7 to 10 days, which we were operating under previously. Let me talk for a moment about vaccine supply. As Deputy Secretary Phillips mentioned, vaccine supply for H1N1 remains very, very limited, and the amount of vaccine that we have available to us on a daily basis remains also very fluid. For an example, on Monday we received an allocation from CDC indicating that we had more than 82,000 doses available to us to be able to place an order on. On Tuesday, that number was at 5,600 doses. And yesterday, on Wednesday, that number was at 0 doses for an entire day that we received no allocation. So what this has done is it's significantly reduced the overall amount of vaccine that we were expecting to have available to us by this point in time. Again, as the chart showed you on that graph, we are operating at about close to 50% less than our original estimates. And so all of the plans that we had in place, the plans that we had for the distribution, the clinic plans that were going to be scheduled by our local health departments, all had to be modified because of the lack of vaccine availability. One particular formulation, the pre-filled syringes, both the pediatric and adult vaccines, have been extremely limited. And we've had a very difficult time keeping up with demand for this vaccine, the request for this vaccine, and being able to send it out for this particular type of formulation. Again, we've been informed by the latest round of estimates that we should hit the 1 million dose mark for vaccine sometime mid to late November. We're very optimistic that if we're able to hit that mark, we'll be able to send out more and more vaccine. We do also realize that the amount of vaccine that has already been sent out to many providers that have received it is not nearly enough, or it has not enough to go meet their initial order that they've placed. So we ask you to be patient with us while we work our ways through these limited supplies. We do have your initial order, and as supplies become available, we will send you your initial order with no need for you to place another order with us. So who have we been reaching out to with the very limited vaccine we have available? The CDC and the Advisory Committee on Immunization Practices, Department of Health and Human Services, all listed out a number of different target groups that they felt were especially important to be able to try to get vaccinated as soon as possible. We've been doing everything we can to work with providers that we think service those target groups. And so we've been sending vaccine, again, to OBs, to hospitals, to pediatricians, to physicians that serve healthcare workers, and to other places, including our local health department. Again, we want to do everything we can to try to reach that 2.9 million mark for our target population as identified by ACIP. We know that seasonal influenza is still occurring and that vaccination with seasonal influenza vaccine is occurring. We want to send a reminder out to providers to be extremely careful because sometimes the seasonal influenza and the H1N1 vaccine can look very similar. Here you see this is a vial of H1N1, and you can see the coloration here. This is a vial of seasonal influenza. These two vials are made by the same manufacturer, and you can see that the coloration on them is very similar. You can see that the coloration on the box is also very similar. So again, we ask people to please be very, very careful when you're pulling out vaccine from your refrigerators before you begin to administer it, and put the adequate steps in line to have checks and balances at all of your clinics, whether they're seasonal clinics or whether they're H1N1 vaccination clinics. Finally, wanted to talk a little bit again about the submission of tracking of doses back to us as a condition of the provider agreement. Providers that receive our vaccine are asked to do a weekly submission of their doses that they're administered. We've tried to create a different ways that you can be able to get that information to us. That will include either using a scan form, which would automatically be shipped to you a few days after you receive your vaccine. We've also developed ways for people to access and use our immunization registry. And we've begun a method where we can work with you to try to help you if you want to do some type of electronic file sharing. Again, because the weekly submission of vaccine doses administered is a condition of the provider agreement, and we ask everybody to work with us to be able to try to get that done in a timely manner. For complete information and details on vaccine tracking and reporting, go to the DHMH website, the H1N1 provider resources page, where we've got some complete guidance and details on that. If you have any questions or any concerns that you want to talk to us about your order, we ask that you please contact our office through email, and here is the email address for you to be able to do that. Again, as Deputy Secretary Phillips said, we get a lot of emails, and we try to work our way through all of those emails as soon as possible. Please know that once you do send us an email, you will receive a response. The last thing to mention is about the vaccine adverse events reporting system. Again, we know that vaccines sometimes have vaccine adverse events, and if you do have a question about that or feel a need to report something, here are two ways in which you can do that: by going to the website, where you'll be given some instructions on how to do that electronically, and then here is also a phone number to be able to do that. So now I'm going to turn it over to Dr. Millstone, who's going to talk a little bit more about vaccination of high-risk children.
Good afternoon. Thank you for joining us. Thanks, Greg. So we recognize that the challenges that are being faced by providers in terms of lots of sick patients, shortage of vaccine, and strained resources. Everyone, including DHMH, has been forced to make difficult decisions regarding allocation of a scarce resource at this point, which is vaccine. So what I hope to talk a little bit about is who we're trying to focus vaccine on and who are in the high-risk groups. When we talk about high-risk groups, we're really mainly focusing on people that are at high risk of complications from influenza. So there are people that have these high-risk groups, and there are those that work with or care for these patients. Approximately 70% of hospitalized patients so far with H1N1 have fallen into these categories of high risk. On the slide, you'll see I've listed the groups considered high risk by the CDC. I think people are very familiar with these now. These are young children, people who have underlying comorbidities like diabetes, obesity, sickle cell anemia, asthma, other chronic lung diseases as examples, people on immunosuppression, and especially pregnant women. The CDC, or the Advisory Committee on Immunization Practices, has recommended H1 vaccine for these groups: pregnant women, people who live or care for children less than 6 months of age, because those children are too young to receive the vaccine, people 6 months to 24 years of age, healthcare workers, and then persons aged 24 to 64 years with underlying conditions. Now this is very straightforward, but unfortunately, as Deputy Secretary Phillips mentioned, we don't have enough vaccine to target all these groups. So I wanted to spend a few minutes giving some practical suggestions as to how to prepare for vaccine allocation to target what we see as the highest risk groups. For example, and I know these strategies have been used by providers in the community as well as hospitals and health centers. Not all patients with asthma are as at risk for complications. For example, someone who's on chronic maintenance steroids is higher at risk than a child who wheezes intermittently. People with seizure disorders that haven't had a seizure in the last couple of years would be less at risk than people who seize frequently and have trouble managing their respiratory secretions. So I think what we're trying to help providers do is to, within their own population, risk stratify which of your patients you think are at higher risk. We know that ultimately all patients will receive vaccine, but as you begin to get your first 100 doses, look at your patient list, look at your providers, and see which healthcare providers have the most frequent contact with places where we're seeing illness. So emergency departments, pediatric practices, family practice offices that are seeing children. A lot of the burden of H1N1 is being seen in younger people and presenting to emergency departments. So those first-line providers should be high on the list for those to get vaccinated. And these are just examples. Please remember that the H1N1 vaccine can be co-administered with the seasonal influenza vaccine. Just a brief word about the two different vaccines. Remember that there is a live attenuated intranasal vaccine that is FDA approved for, quote, healthy people between the ages of 2 years and 49 years of age that are not pregnant. It's important to ask patients before if they have wheezing or underlying lung disease. These would be contraindications to getting the intranasal vaccine. It can be given to breastfeeding moms, this has come up, as well as people who have close contact with high-risk patients. There are some exceptions to this, including patients who've had bone marrow transplants recently. There also is a monovalent inactivated vaccine, the injectable vaccine, which is more widely available at this point, or I should say becoming more widely available. How many doses are people going to need? Preliminary data, this was actually just updated by the NIH in the last couple days in the CDC. Data has come out showing that in the 6-month to 35-month age group, after the first dose of vaccine, approximately 25% of children will have a serologic response that we think will provide protection against the virus. After a second dose, this came out a couple days ago, 100% of children had protective antibody levels. In the 3 to 9 month age, similar, after one dose, it's only about 36 to 55% after the first dose, which reaches 100% or near 100% after a second dose. So based on this, it is going to continue to be recommended that children under the age of 10 receive 2 doses of vaccine separated by 28 days. One other thing to remember logistically about giving or administering the vaccine, it's not encouraged that both the seasonal influenza intranasal vaccine as well as the H1N1 intranasal vaccine be co-administered. It is okay to co-administer the seasonal vaccine and the H1N1 vaccine. They can either both be given as injections, or one can be given as an injection and one can be given intranasal. But 2 intranasal vaccines should not be co-administered at this point until further studies have been done to look at efficacy. It's also important to remember for practitioners that the vaccine is not 100% effective. So just because you have a patient who is vaccinated who comes in with flu-like symptoms, it doesn't mean that they do not have influenza. Just a couple brief comments on who to treat. This has become very challenging. As you know, there are lots of things we're seeing in the community in addition to H1N1. We're seeing lots of rhinovirus, we're seeing lots of parainfluenza virus. Not all children who come to your practice will have H1N1 with an influenza-like illness. The recommendations from the CDC, though, are to consider early therapy in children or others that are considered high risk. So again, we go back to the high risk category I mentioned on the first slide. Those apply for both treatment as well as vaccine prevention. The last update from the CDC was on October 16th. They encourage all hospitalized patients with H1N1 or presumed H1N1 receive antivirals. Again, I've listed the website here for who are considered high risk at the CDC. Especially consider in patients with moderate to severe disease. Don't wait for laboratory confirmation. We know that a lot of the rapid tests are only 50% sensitive at detecting H1N1, and the delay in return of the test should not preclude you from treating someone empirically if you think they have H1N1. And just one comment on prophylaxis. There are some recommendations from the CDC on who to prophylax. Most of the cases of oseltamivir resistance to H1N1 have been seen in people that are receiving prophylaxis for exposure. Given the burden of influenza in the community, that's the number of people that have H1N1, we expect that people will continue to be exposed in the community, at school, throughout the winter. So I think the role of prophylaxis is limited unless we plan on using prolonged prophylactic treatment course or prolonged prophylaxis courses for people that may have repeated exposure. We are advocating for following patients closely for development of symptoms and utilizing early empiric therapy over prophylaxis, but I think that needs to be handled on a case-by-case basis given patients' underlying risk. Thank you. Oh, one more slide. I did quickly put this on. This is a slide on the CDC website again about treatment of H1N1 in children. This gives dosing for children under 1 year of age. The reason I just wanted to point it out to clinician at the Maine Infectious Disease Society meeting last week, there was a study that was presented by the antiviral study group at Alabama where they have found mg per kg or milligram per kilogram dosing for oseltamivir in children under 1 year of age. This has been reviewed by the FDA and will likely be endorsed soon, but the recommendations are on the CDC website.
Thank you very much to all of our panel members. We now have the opportunity to take questions from our web audience. And for those, again, who want to send a question, please send your questions to us at maphtc@jhsph.edu. Our first question is, have there been any deaths among the elderly in Maryland due to H1N1? Dr. Blythe, maybe.
Take that quickly. The quick answer is yes, there have been. In Maryland and nationally.
Yes. Please define healthcare works. Does this healthcare workers? Does this include housekeeping and maintenance that frequently go into patient rooms and inpatient units, or just those with direct care responsibilities?
Take a stab at that too. It would include anybody who is coming in direct contact with patients, in close contact with patients where there might be transmission one way or the other.
Can I add to that?
Sure.
This has been a very challenging question because as people recognize, there are lots of providers that have face-to-face contact with patients, from social workers, case managers, environmental services, nutritionists, you name it. So I think as vaccine comes out initially, we've tried to consider using sustained patient contact or people that are going to potentially contact with respiratory secretions, not those that are simply walking into a room knowingly and could put on protective equipment before doing it. I think that will change as more vaccine comes, but I think again, that's a group that should be stratified as there's a shortage of vaccine.
Okay, there's sort of several things involved in this question. Can you please explain how prioritization is decided? Detention centers seem to make it on the list earlier stated, but having pre-registered in early September, our immunology office hasn't received anything. So I think there's questions both about the priorities and also about the distribution system.
Well, I'll talk generally, and I know Greg will have some additions for specifics. We're guided first and foremost by the target population. So who are the providers who are most likely to be in contact either as primary care providers or as other providers with that target population? So again, that eliminated some groups who are more oriented to the general public and prioritized the providers such as local health departments, pediatricians, hospitals, family practitioners, and federally qualified health centers. So one category that we look at is what kind of provider. We also want to make sure that there's geographic distribution across the state. So we look very carefully at, amongst all the registered providers, what is the distribution within each jurisdiction so that we are able to make sure that there's at least one provider who is able to be the safety net provider, and in every jurisdiction that is the local health department. So in terms of allocating doses, we look at what other providers might be in that jurisdiction that serve both the pediatric, the pregnant, and the adult population. And so that's one round of reflection that guides the determination as far as the number of doses, and then that is further scrutinized with regard to the different formulations. So that's kind of a general overview of some of the principles that go into the daily allocation, and probably you have some things to add to that, Greg?
Yeah, The key thing to remember is that as we receive additional supplies of vaccine, we will be able to distribute additional supplies of vaccine. What we want to do, as Deputy Secretary mentioned, is to make sure that those places where we know we have those target groups, as identified by ACIP, described by Dr. Millstone, are receiving vaccine. And we are working our way through all of the vaccine requests that we have. And again, we're very hopeful that as additional supplies of vaccine come in, we'll be able to distribute those out to everyone. We do have everyone's order. There is no need to place a reorder, and we are very much working our way down, trying to distribute this vaccine as soon as it comes in.
Okay. This is a medical question. Will immunocompromised patients need a second dose of H1N1 vaccine?
Shot at this one too, but at least the current, the studies, there are some studies ongoing, and so it'll be a little bit. Some of this is not fully answered for this H1N1 vaccine or for seasonal flu vaccine, but at least at this time there is no recommendation for a second dose of vaccine for immunocompromised patients. The only group at this point for whom there is a recommendation for a second dose is those children 9 years of age or younger. And I don't know if Dr. Millstone wants to add anything.
I think that's great. I would just add that there is an NIH study looking at this in HIV patients, whether or not there's an advantage of a second dose. But it's also important to recognize that some immunocompromised patients will not respond to vaccines. So I think providers need to make a careful assessment. I wouldn't waste vaccine now. I shouldn't say waste, but I wouldn't use early vaccine on patients that are unlikely to respond. But I think we should be giving it to patients that are immunosuppressed that will respond to vaccine.
Okay. If Head Start is a licensed daycare provider, are they mandated to have the parent present during vaccination, or is the consent form sufficient?
Consent form's fine. Consent form's fine. Got to have parental consent, whether it's for daycare or for any minor in any setting, including a school setting. So. And certainly the daycare population is generally a healthy population, but nevertheless it's this younger group that we're seeing proportionately more disease in, so that would certainly be a target population. Daycare providers typically do not have licensed clinicians on staff, and so daycare providers are encouraged to work with their local health department to work out an arrangement by which children there can be vaccinated. And there's a variety of methods to get that accomplished. But yes, the consent form is absolutely necessary. These are voluntary immunizations, both for daycare and for school-age children, K through 12. But for any minor, the consent is necessary, but the parental presence is not necessary.
Does the term carefully prioritize mean a provider can redistribute the amount of vaccine received if still in accordance with CDC guidelines?
If the question relates to a provider receiving a supply of vaccine and then redistributing that to another provider, then we would discourage that type of practice. We do have a process where providers can indicate to us that they want to receive vaccine, and again, we're working our way to try to be able to give vaccine to individuals as soon as possible. But the sharing of vaccine, the loaning of vaccine, the redistributing of vaccine from one doctor to another doctor is not a practice that we're encouraging.
Let me just say that there has been some of that in various parts of the state, and very well intended. There's problems with that. The first, of course, is cold chain. To maintain the cold chain when vaccine moves and moves and moves, then there's increased risk that the vaccine itself might be compromised. Secondly, there is the provider agreement and really the accountability for that vaccine to go to an individual who is part of the target population, that there is the full dose tracking form that is done, that there's no fee that is charged with respect to the vaccine itself. So there are a number of contingencies, which is why we have these provider agreements with over 2,000 providers now. We do know that there are contingencies in different parts of the state that wherein providers, whether it's private physicians or hospitals, have worked on a short-term basis with local health departments. And to some extent, when there's just an exigency that needs to be the resolution, then that would be acceptable. But what is not acceptable is the wholesale, what we're calling regifting. We have a system, and what that does is that subverts the system so that when there is vaccine that travels from where we think we've ordered to other providers, what that does is it skews the database that Greg and his office works from in future orders, in future days, so our understanding of actually where the vaccine is compromised. So we would urge that not take place. If there's a particular instance where it is felt to be crucial, absolutely contact Greg Reed and his staff, and we'd be glad to work with you on that.
Asthmatics account for 32% of the patients admitted in U.S. hospitals. What provisions have been made to get the vaccine out to the pediatric and allergy physician offices that serve them?
Again, those places, practices, hospitals that serve that type of population, which are again fall within the Advisory Committee for Immunization Practices scope of priority groups, we are working very hard to try to make sure that those places receive vaccine. Out of all of the vaccine that we've received, more than 18% of it has gone out to pediatric practices, and more than 18% of it has also gone out to hospitals. So again, these are places where we know that these type of patients are being seen, and we're working to try to make sure that we continue to prioritize those facilities to be able to receive the vaccine, because we know that they're serving those high-risk children and those high-risk populations as identified by ACIP.
Can a nasal flu vaccine cause a false positive rapid flu test?
Yes, it's not really a false positive. It is actually detecting the virus, but it can cause a positive flu test. And so that is an issue for people who are administering the nasal vaccine. If you have a patient or people who are seeing patients and relying on influenza testing, if you have a patient who recently received the nasal vaccine, that could, in fact, give a positive test, both the rapid antigen test and also the RT-PCR testing that would be done at some of the labs, including our own state public health lab. So the answer is yes.
How long should you wait between? Like, is a month later okay, or 2 weeks later, or do you know that?
To test?
The question is, how long should you wait between, and I don't, to wait between testing?
No, if someone got the nasal vaccine, I mean, can you never test them for?
I think the answer is yes, you can test them. The test would need to be interpreted in the context of the recent receipt of vaccine. And, but I would just overall stress that the decisions about treatment, for example, need to be based not on test results, but on clinical judgment and clinical assessment. And
no, that's just to clarify, the question was how soon after can you test? And I think Dr. Blythe is correct in really emphasizing that if someone is given an intranasal H1N1 vaccine and 3 or 4 days later, I've gotten this call repeatedly, 3 or 4 days later they come to your practice with fever, lethargy, congestion, they most likely have H1N1. So if your test is positive, it's likely going to be because of the virus, not because of the vaccine. I think right now I would treat the patient clinically, and again, the tests that we have available right now, especially the rapid tests, are not that sensitive, and so I would be careful with the test, and I would treat the patient clinically. And one more comment on that I've gotten repeatedly with regard to this is if you have a patient who gets the H1N1 vaccine who comes in within a week or so with a flu-like illness and you treat them with oseltamivir, that drug will also kill the H1N1 vaccine virus. So effectively you should then redose them with the vaccine later, assuming that their vaccine was not efficacious.
Okay. Can we bill patients for the administrative fee if insurance does not pay the fee?
Yes, patients can be billed. However, there is a maximum cap on the amount of that billing can be done, and that's based on the federal guidelines in terms of the Medicare reimbursement rate for the state of Maryland. We have some detailed guidance on financing, on billing, on the DHMH website, and we encourage people to take a look at that to be able to help answer some of these more detailed and technical questions.
Follow up on that, with regard to reimbursement, as Greg said, yes for an admin fee, no for the vaccine itself, of course. Health department vaccine is free, both respect to the vaccine itself and administration. So there'll be no charge to the patient for any vaccine administered by local health departments. Providers can bill for their effort, for their time, for their overhead in terms of vaccinating individuals. And fortunately, in Maryland, the major payers, as well as Medicaid, have indicated a willingness to reimburse for that administration fee. So that's forward-looking as far as the participation on the part of the payers, so that reimbursement will be there for the administration fee as it, I think, typically is, and at least for private payers with respect to seasonal flu.
Okay, thank you. Is there any way we can get a schedule of delivery? It is difficult to prepare clinics when we have no idea when the vaccine is coming and how much we are getting.
It's a great question. I wish we had better way to know exactly how much vaccine will be available and when, so that we could give people really a great forecast about overall doses and the overall arrival of vaccine here in Maryland. One thing we are trying to do and working on, hopefully those of you who've received, had orders placed recently are aware of this and seeing this, is notifying providers when vaccine is ordered for you, so that you're aware that at least vaccine's been ordered and you can be prepared from that standpoint.
Yeah, and just to add one more thing that what Dr. Blythe is saying is that we are sending out now emails after we submit an order to the distributor. We're sending an email to the person that's listed as the point of contact for that facility, for that practice where the vaccine is going to be going. So again, we ask you to please check your email, and that email again is a rather general email telling you that an order has been placed for you and gives you a general time frame of when you can expect to receive that vaccine. Again, we're working to try to improve that and to try to make that much more customized, and we're hoping to be able to have something in place within the next couple of weeks to be able to help us with that.
Okay, next question is, I emailed a question to H1N1 info website multiple times, but have yet to receive a response. How quickly do you respond to emails?
That's a very good question, and again, that email mailbox, we receive a lot of emails coming through that mailbox, and we have a number of staff that are reviewing that email box, you know, staying on there every hour, as the point may be. If you haven't received a immediate response to the question that you submitted, that means that we're trying to figure out an answer. We get a lot of very technical questions in terms of where is my order, and which requires us sometime to get in contact with the distributor to try to do some tracking, or to be able to talk to other people like Dr. Blythe sometime when people have clinical questions, because we want to make sure that we will respond with an appropriate and a correct answer. On the whole, we do have a policy. We try to get back to everybody that submitted an email within 48 hours. So again, if the person that submitted an email that has not received a response, I do ask that you send that in again, and you can indicate that you saw this webcast and say you want Greg Reed to personally respond, and I'll do my best.
Okay. Where are the long-term care providers and their healthcare workers falling into the priority? We have residents who are swabbing positive and are virology positive for H1N1. However, we're not receiving any doses.
Yeah, that's absolutely true, and that's one of the groups that long-term care providers have registered and have not received vaccine because of the stratification of the providers that we have used in order to segment what is a very tight supply. Now, we have watched closely both the outbreak reports and the disease in general, and again, this has been a young person's disease by and large. That's not to say that there haven't been elderly people who have been infected. It's also not to say that only elderly people live in long-term care facilities. So I understand that can be a mixed population. But across the board, at this point, we have not sent vaccine to long-term care facilities. Again, I want to emphasize that a fail-safe in every jurisdiction is the local health department. And so while local health departments are certainly not flooded with vaccine either, they should be a resource for every provider group who feels that there's a local need that has been unattended for, or if they have questions. Every local health department now across the state has H1N1 vaccine information on their homepage. And so in order to reach, in any county, that homepage, what you can do is go to the state website, which is the www.flu.maryland.gov. Go to that website, and then you can link onto the county, and that will link you to the county health department website. So for long-term care providers and other providers for whom there are needs and there's simply not vaccine available, I do encourage you as a kind of a provider of last resort to contact your local health departments. Health departments have been terrific partners in this engagement around the state for the last 4 weeks. They are leaning forward now to make very public and kind of going out on a limb as they're leaning forward, the limb being they don't know exactly how much vaccine they will have when they announce public clinics, but nevertheless in the spirit of assertively getting the vaccine from their shelves and into at-risk people, health departments are announcing public clinics by a variety of modes, whether that's by appointment only or targeted to specific populations. So health departments now are becoming much more visible with how the public can access vaccine through their locations and at their sites. So again, those are websites that are updated every day, so that I would encourage both the public and providers who are looking for vaccine and don't have any to check with the local health department.
Okay, here's a question for Dr. Millstone. Can kids with autism receive nasal H1N1 vaccine?
If that is their only underlying comorbidity, I think that would be a reasonable population for the H1N1 intranasal vaccine, yes.
Okay. What are individuals who die from H1N1 actually dying from? What are the specific complications? Is it because they sought delayed treatment?
I can take a start at that. Really three main things. One is that some people are dying from, and this is true in Maryland, but also nationally, and I'm sure internationally as well. Some people are dying from direct effects of the virus itself, or the viral infection itself. So viral pneumonias and other complications of influenza itself. Some people are dying, those people who die have co-infections with other organisms, and in particular bacterial co-infections with bacteria like Staph aureus, for example. So co-infections. And then some people are dying from underlying conditions that are exacerbated by the influenza infection. So, for example, congestive heart failure that gets worse because of an influenza infection, and then causes death from those reasons.
Okay, this question represents a variety of questions that we've gotten here about more or less administration of the vaccine by a practice. This is an urgent care center. Once we received the vaccine, knowing that we're not a provider that serves strictly the target population, are we only to vaccinate the target groups?
Yes.
Should we turn away people who aren't in the target groups but wish to get vaccinated?
The vaccine that was supplied to urgent care centers as well as to other vaccinators has been specifically, at this point in time, restricted to the use for the target populations. So if urgent care centers are not seeing sufficient numbers of target populations, I think that that's kind of unlikely. But if that's the case, then we will amend those orders in the future. But the point is that the vaccine that has been supplied to providers is for the purpose of the administering to the target population.
I want to add one thing to that. I can't agree enough. In our institution, we've been inundated with requests from people who have grandkids or people who are not in the criteria for early vaccination. And it only takes seeing one child or one patient die from influenza to compel yourself to say no to that person and give it to someone who really is at high risk of death from influenza. So please do your public service and give it to the groups that it's intended for.
Okay. During the last seminar, it was indicated that DHMH would be creating a change of order forms to be able to switch from the multi-dose from pre-filled syringes into the multi-dose vials. Since the pre-filled syringes seem to be slower in being released, has this form been created, and if so, when can we expect to receive it?
That process has been done for hospitals. We wanted to make sure that those hospital facilities, which by and large had placed the majority of their order for pre-filled syringes, to be able to have some flexibility with that order. We're having current discussions now, again, based upon the vaccine supply and the estimated amounts of vaccine that we're expecting to be receiving, as to whether or not we should be expanding that out to all of the providers that have placed an order with us. And then the final thing that we're doing in my office is every time we have an order, we're assessing that order to see whether or not it is we are able to swap out a request for pre-filled syringes with the multi-dose vials, and we will be doing that automatically.
Okay. Given the limitation of supply, any thought to limiting vaccination to those who have already suffered a flu-like from those who have already suffered a flu-like illness?
That's a good question and a good point. So, so I'll try to address this. So it is possible that people who've had influenza, H1N1, the 2009 H1N1, would be immune and therefore would not really benefit from vaccine. And so but overall, most of the people who have had influenza-like illnesses have not been tested and not been confirmed to have H1N1. And so as you've heard earlier, there are other viruses circulating, for example, respiratory syncytial virus, the para-influenza viruses, et cetera, that can cause very similar illnesses. And so we can't assume that a person who had an influenza-like illness had 2009 H1N1, unless they really had the RT-PCR testing done to confirm that. So overall, the recommendation is that people, even if they've had a recent influenza-like illness, if it wasn't confirmed by laboratory testing to be the 2009 H1N1, that those people those people should be vaccinated. So I don't know if you want to add.
No, one more general comment. I think people need to recognize that it's hard for us as vaccine advocates to sit here and say not to vaccinate people. So I always make sure when someone comes up to me and says, I really want to get the vaccine, am I in a high-risk group? If they're not, I smile and say, thank you for your interest. Please come back in a few weeks when we have more vaccine. Our intention is still to vaccinate everyone, so don't make people upset thinking they're not special, but encourage them to come back in a few weeks.
Okay, I'm just going to ask for a yes on this, because the question, I think, repeats something that was already indicated in the presentation. Can nursing mothers get the mist instead of the shot? And I believe that's a yes.
Yes.
And here's another quick answer, I think. What is the rise of serious complications from getting the H1N1 vaccine?
I'm sorry?
What is the rate or risk of
okay,
serious complications from getting the H1N1 vaccine?
I'm happy to as well. I'll start. Okay, we'll tag team this. But yeah, that's a concern. I know that really there haven't been, in the studies that have been done looking specifically at this vaccine, there haven't been serious adverse events identified. And overall with the influenza vaccine, that's generally the case as well. A very safe vaccine. Certainly people have adverse effects related to it, and in particular they have pain at the site of injection if it's the injectable vaccine. And so there are side effects and effects of the vaccine, but not the serious adverse events that people have been concerned about.
I agree. The risk of getting a serious complication from influenza exceeds the risk of getting a serious complication from the vaccine.
Okay. Should I immunize my patients that are over Guillain-Barré syndrome?
The current recommendation is if you've had Guillain-Barré syndrome in the last 6 weeks, you should not get the vaccine. Beyond that, there should not be an exclusion.
And if I can just add, we do, though, want to, as a department, are very interested in hearing about any possible Guillain-Barré cases during this time period. So if providers are seeing someone they think may have Guillain-Barré, please report that either to the local health department or to the state health department. I know we've sent out notices to folks about that, but just want to really encourage that so that we can carefully track that particular concern that has been brought up by many people about the possible association between Guillain-Barré syndrome and this vaccine and influenza vaccines in general.
For people getting questions about side effects following vaccination, there was a very nice article published in the Journal of the American Medical Association the last month or two that looked at background rates of disease, and it emphasized that people there's a background rate of Guillain-Barré syndrome, and if someone gets Guillain-Barré syndrome after vaccination, it's not necessarily a causal association. It's a very important article that talks about background incidence of lots of diseases in the community. If you're getting these questions, it's probably a good reference for you to read to help better educate your patients that are asking these questions.
Okay, we are at 1:30 now, which I believe is supposed to be the scheduled end of this webcast. The questions that I've got are all might be called distribution and facility questions. People who have more vaccine than they need to use and want to know what to do with it. People who haven't gotten any vaccine yet and want to know when their vaccine is going to come. So what I'd suggest we do is take the email addresses of the people who have sent these specific questions and give them to Greg, and Greg and his staff can follow up on them. So as we conclude today's event, on behalf of the department, I'd like to express the department's appreciation to Johns Hopkins School of Public Health, the School of Medicine, and most particularly all those participating in today's webcast. And again, a reminder for Professor Mitchell, please complete the evaluation form on the web. The webcast will be recorded and available on this website and on DHMH's website in the future. And again, please try to give us a feedback on our session so that we can do better the next time. Thank you for participating.